Good evening and welcome. I'm Michelle Daly, the family therapist on the oncology team at Norwalk Hospital, and we're so pleased that you all have joined us tonight for our monthly breast cancer lecture series featuring guest presenter Dr. Lisa Phuong, who will address with us and perhaps demystify the sometimes overwhelming task of understanding lab values. We're thrilled that Dr. Phuong joined our breast team at the Whittingham Cancer Center, Norwalk Hospital in July 2021. And those of us who have the pleasure of working with Dr. Phuong can easily confirm that she has quickly and seamlessly become an integral part of our cancer center, bringing clinical expertise and compassion to the management of breast cancer. Dr. Phuong came to us in Norwalk following hematology oncology fellowship training at Montefiore Medical Center and the Albert Einstein College of Medicine in the Bronx, New York. And prior to that, she completed internal medicine residency at the University of Connecticut Health Center in Farmington. She received her undergraduate degree at the University of Pennsylvania, followed by a Master of Science in Biomedical Sciences at Rutgers, and then on to receive her medical degree magna cum laude from Touro College of Osteopathic Medicine in New York City. She presently holds board certifications in internal medicine and medical oncology, with a third board certification in hematology forthcoming this year. Dr. Phuong has extensive clinical research experience and has published numerous academic papers and articles in peer-reviewed journals. As you'll see tonight, Dr. Phuong will quickly put you at ease, even while tasked with the enormous feat of translating the intricacies of your lab values into a more meaningful package of take-home information. It is indeed my privilege to work with you, Dr. Phuong, and to welcome you to our program this evening.
Thank you so much for that warm introduction, Michelle. I really appreciate it. I'd like to welcome everyone. Good evening. I will be talking about lab values and lab tests, particularly in breast cancer. I do want to start off by saying that this lecture series is geared towards patients. I know that there are other physicians and providers on the call as well. If there's anything, detailed and more thorough in terms of, explanations, feel free to email me as well. I have no financial disclosures to report. And, I will be talking tonight very briefly about basic blood tests that are done in breast cancer, pathology, certain pertinent information in those path reports, including staging, grade, and biomarkers like estrogen, progesterone receptors, and HER2 receptors that help in terms of prognosis as well as, guidance in treatment and management. I'll go on to discuss genomics, specifically about Oncotype recurrent scores, and I will spend some time on that just because it has changed the treatment landscape in terms of management for hormone receptor positive breast cancers. And I'll discuss, some about tumor markers as well as circulating tumor cells. So lab tests in breast cancer do include a whole range of things, including blood tests, tissue biopsies, and imaging. And all of these in combination help diagnose cancer. They help provide information about staging, guide treatment. They help to monitor one's overall health as well as side effects and toxicities from treatment. They determine treatment response, and they're also used to help find out whether cancer has recurred, come back, or whether it's metastasized. So blood tests, and I'm going to say this over and over again, are not used to diagnose breast cancer, but they can help get a sense of one's personal overall health. For example, they can be used to determine if a person's healthy enough to undergo surgery or receive chemotherapy. We also use these tests to monitor side effects and toxicities from one's treatment. In terms of what we look at when we do routine blood tests, One of the common tests that we use are CBCs, or complete blood count. And the specific numbers that we look at include those called white blood cells. If they're low, they give us an idea of how of whether someone's at risk of infection. Hemoglobin, the hemoglobin part of the CBC, basically measures the oxygen carrying capacity of those red blood cells. So if they're low, they can be indicative of anemia, and they also, basically show that someone could be having fatigue from, say, their chemotherapy treatments because of their anemia. Platelets, also if low, can give us an idea of bleeding and bruising too, and that risk in those patients. The other tests that we look at include the comprehensive metabolic panel, and the CMP can help determine electrolyte abnormalities, or if organs such as the kidney or the livers aren't working well. Furthermore, if there's suspicion that cancer may have spread elsewhere, sometimes, not all the time, but sometimes certain lab values can be suggestive of that. For instance, if there's concern that cancer has spread to the bone, we might be seeing elevated calcium levels and something called alkaline phosphatase. If we're concerned that breast cancer may have spread to, say, the liver, we might see abnormal LFTs, liver function tests, including AST, ALT, and bilirubin too. And in those who are getting systemic treatment, specifically chemotherapy, we do always check a hepatitis panel. And the reason why is that for patients with a chronic or an active hepatitis B infection, those patients who might not be aware of it either, they are at risk of Hep B reactivation during and after chemotherapy, just given the immunosuppression that they have from their treatment. And so there should be preemptive antiviral therapy for their hepatitis. So just like I said, blood tests are not used for breast cancer diagnosis. And this has been shown in various studies. For instance, specifically, there's no added benefit in the detection of underlying metastatic disease in patients who are asymptomatic and early stage, with early stage breast cancer. There was a chart review that was conducted of 1,600 patients with invasive breast cancer who were treated at Dartmouth from 2005 to 2009. And there were, of these 1,600 patients, there were 1,000 patients who had early stage breast cancer, clinical stage 1-2 disease. About 27% of them had abnormal blood counts, 25% had abnormal LFTs, and that led to 84 additional imaging studies. Of these additional imaging tests, no metastatic disease was detected, meaning that these blood tests are non-specific and they do not improve detection of metastatic disease. But what it did show was that it resulted in additional financial costs. As you can see, $110 per patient for blood tests and chest x-rays, and then with additional tests altogether leading to a total of $58,000 in terms of cost. There's also no benefit in terms of pre-op screening for metastatic disease in patients who were clinically node negative, meaning that there was no lymph node involvement seen in terms of imaging and physical exam. This was based off of a retrospective chart review of about 1,600 patients, again with early stage breast cancer, stage 1-2 disease, and node negative disease, who were treated at Wake Forest from 1998 to 2015. So 94% of patients had at least a screening test, whether it be blood work, CBC, LFTs, or chest x-rays. And of those, you could see the percentages: 36% CBCs, 13% LFTs, and 7% chest x-rays were abnormal. So that was followed up with CAT scans. And 17 CAT scans in this chart review were found, and one of them did reveal metastatic disease. That one patient, though, that was found to have metastatic disease was actually already at clinically high risk of having that, because one, it was a male patient, and two, he had presented with synchronous bilateral invasive breast cancer. So based on this chart review, pre-op screening in clinically node negative breast cancer is actually low yield. And even when abnormalities are found, metastasis is present in less than 1% of those patients. And we do have to remember that a normal study, normal imaging tests, do not rule out metastatic disease. So now moving on to pathology. As we all know, staging is a very big part in terms of breast cancer diagnosis, prognosis, and it helps determine treatment management. Staging is based on the 8th edition of the American Joint Committee on Cancer, AJCC, the TNM system, tumor node metastasis. Basically, I say 8th edition, and there are periodic revisions that are done from time to time because advanced imaging techniques as well as treatments evolve over time, and they do impact survival, thus impacting the staging system. The relevant staging criteria that we look at in terms of prognosis and management include both the clinical stage as well as the pathologic stage. So those are two different kinds of staging systems. The clinical stage is based on the physical exam, the imaging, as well as biopsy results. So this is done before surgery is done. And the pathologic stage is based on the findings from surgery. For instance, if someone's having a lumpectomy, mastectomy, etc., and the information that's used from the clinical staging as well. So, like I said, breast cancer is staged according to the tumor size, and I'm going to say of the invasive disease. As many of you might know, there can be components of, say, DCIS or ductal carcinoma in situ that's mentioned in the path report. Those are not included in tumor size when we stage for invasive disease. We also look at if and how many lymph nodes are involved and whether there is metastatic disease, meaning whether the breast cancer has spread outside of the breast, outside the lymph nodes into other organs of the body, like the liver, the lungs, and the bones. The 8th edition, what makes it different from earlier editions of the staging system is that the 8th edition now incorporates biomarkers into the staging to create prognostic stages. And basically, these include hormone receptor status, ER, PR, estrogen receptor, progesterone receptor status, HER2 status, the grade, and sometimes genomics, meaning Oncotype recurrence score, which again, I will be going into in a few minutes. So this is a diagram that's taken from MSK. Basically defining the stages of breast cancer. This is sort of a simplified view for our patients. Stage 0 is a non-invasive type of breast cancer, which I will not be going into tonight, but just, basic is that usually when breast cancer cells start, they start in the milk ducts of the breast. And if they haven't invaded the breast tissue, that's what, we define as ductal carcinoma in situ, or stage 0. Moving on, our invasive breast cancers are staged from stage 1 to 4. And as you can see, early stage 1, cancer has spread to other tissue in small area, meaning basically localized to the breast tissue itself. Stages 2 and 3 could, is dependent basically on the tumor size. The larger it is, the higher the stage, as well as lymph node involvement. So as you can see, stage 2, localized, tumors between 2 to 5 centimeters. And some lymph nodes could be involved, or there's a tumor larger than 5 centimeters with no lymph nodes involved. Stage 3, the tumor is larger than 5 centimeters with more lymph nodes involved. And in some cases, the cancer may have just spread to the skin or the chest wall. There might not be a tumor that's present at all in the breast. And then stage 4 is distant spread. Unfortunately, that's metastatic disease, and that just means that cancer has spread beyond the breast to other parts of the body, like I said, liver, lungs, for instance. So staging does serve as a prognostic marker in breast cancer. This is based off of the NCI, the National Cancer Institute SEER program. So SEER stands for Surveillance, Epidemiology, and End Results Program. And basically this program collects cancer data in the US and it compiles national cancer statistics. Before I go on further, basically this table is looking at the 5-year relative breast cancer survival in the US. And relative survival compares survival for people with breast cancer to survival rates for people, women in the general population. When we look at this, the SEER staging category isn't specific like normal, like stages 1 to 4. It's actually more broad. So you see local, regional, and distant, and there are definitions for that. So Local means that the cancer cells have not spread beyond the breast where they started, and that translates to a 99% 5-year relative breast cancer survival. So that means that women with localized breast cancer are on average 99% as likely to live 5 years beyond their diagnosis compared to women in the general population. And that applies again to the regional category, where cancer cells have spread beyond the breast, but it's limited to nearby lymph nodes. So 86% 5-year relative rate, and unfortunately distant, it continues to drop to 29% when that's stage 4 disease. It's important to know, though, that this table should not be individualized, that relative survival rates are averages, right? And they vary depending on each person's diagnosis and their treatment. So this is less helpful in terms of estimating the survival rates for individuals because, again, like I said earlier, the stages are very broad. It's also important to know that these numbers are based on women who were diagnosed, and as you can see from the reference below, these women were diagnosed with breast cancer between 2011 to 2017. Everyone knows this, treatments have progressed. I mean, treatments have significantly improved over time. And so these numbers are based on women who are diagnosed and treated at least 5 years earlier. So, we might expect that these numbers would be higher. Another important thing to note is that these numbers also apply only to the stage of the cancer when the patient was first diagnosed. So it doesn't apply, to cancers that have spread later on or progressed, or any kind of cancer that has come back after someone's already been treated. And lastly, I do want to add that these numbers don't take everything into account, which is why I say, sometimes it's hard to give someone a specific percentage, right? Because these survival rates are grouped based on how far the cancer has spread only. And again, it's a broad category. But one's age, one's overall health, other comorbidities, other medical issues, and how well the cancer has responded to treatment, the grade, the hormone receptor status, HER2 status, other factors also affect, one's outcomes, one's outlook. So, for instance, women with triple negative breast cancers, unfortunately, it's a more aggressive subtype of breast cancer, might actually have, lower percentages compared to what you see on the screen. So another thing is histologic grade. I keep talking about grade, and that's also, another way in terms of predicting prognosis. The histologic grade is based on how much cancer cells look like normal cells. I don't know if there's a pathology talk later on in the series, but potentially if there is, then they can go into more detail with this. But basically, it's determined by assessing morphologic features, tubule formation, nuclear pleomorphism, and mitotic count. Basically, the gist of this is that, the more aggressive, the more abnormal appearing, the cells are, then the more aggressive appearing they might be. So it helps predict prognosis. It's been shown that there's a correlation between histologic grade as well as prognosis, that is breast cancer specific survival. Breast cancer specific survival is basically the length of time from one's diagnosis to their death from cancer specifically. And there's a correlation with disease-free survival, which is the length of time from one's end of treatment until the disease, returns. This helps guide treatment decisions, and grading goes from a score of grade 1 to 3, with grade 1 being well differentiated and grade 3 being poorly differentiated. Grade 1 meaning that the cells are slower growing, they look more like normal cells, as I mentioned earlier. And grade 3 poorly differentiated meaning that the cells look very different from those normal breast cells, and they're most likely going to grow, and spread faster. This again is grading for invasive breast cancer. For ductal carcinoma in situ, DCIS, the grading is, somewhat similar. So there have been studies evaluating whether the Ki67, Ki67, which is seen in pathology reports, can serve as a prognostic value in breast cancer. And, it's been looked at to see how useful it is in predicting response and clinical outcome. And so the Ki-67 is what we use to measure the rate of cancer cell proliferation. So the higher it is, the higher, cancer cells are dividing and things like that. There was a meta-analysis of over 40 studies that involved over 12,000 patients that report that high Ki-67 levels were associated with a higher risk of relapse, as well as a decreased breast cancer specific survival, regardless of whether or not lymph nodes were involved. But this is controversial because of tumor heterogeneity, as well as inconsistency with scoring across labs. Factors that contribute to, say, interlaboratory discordance included tumor region selection, just meaning, spots that were selected for measuring the Ki-67, the counting method, as well as the subjective assessment of staining positivity. There was a multi-institutional study too that demonstrated poor lab-to-lab validity, even among some of the most respected labs, in the world, like MD Anderson and the NCI, National Cancer Institute. So standardization of tissue handling, of the tissue processing is needed to improve the reliability of and the value of Ki-67 testing for now. Moving on to biomarkers, specifically estrogen, progesterone receptors, and HER2 receptors. These receptors are proteins that are located in or outside of the breast cancer cells, and they can attach to certain substances to help grow and to potentially spread. And like I tell my patients all the time, the reasons why we check for these receptors is one, because it can help give us an idea of how aggressive the cells could be. It serves as a prognostic marker too, and it also can help decide what treatments the patients might benefit from. So normal breast cells, as well as some breast cancer cells, do have hormone receptors, specifically estrogen and progesterone receptors, okay? And obviously these attach to estrogen and progesterone respectively. And if they do so, then that helps them grow rapidly in an unbridled manner. When breast cancer cells express either estrogen receptor and or progesterone receptor, that's when we call them either ER positive or PR positive, hormone receptor positive. And when these cells don't express any of these receptors, then that's when we call them hormone receptor negative breast cancer cells. About 7 out of 10 breast cancers have at least one of these receptors, estrogen and progesterone or progesterone. And this is why, estrogen and progesterone receptors should routinely be tested on all invasive breast cancers, as well as, DCIS. Just because, one, again, prognosis, and two, it helps with treatment decisions. Let me just go back to my last slide. Before I go on further, I do want to compare a little bit, hormone receptor positive breast cancers versus hormone receptor negative breast cancers, because I did mention that it gives us, an idea in terms of prognosis and whatnot. Basically, hormone receptor positive breast cancers, as we know, we are able to treat with hormone therapy or anti-hormone therapy, endocrine therapy, or what have you, okay? Whereas we would not do that for someone who did not express these whose breast cancers did not express these hormone receptors. Hormone receptor negative breast cancers tend to grow faster than hormone receptor positive breast cancers. And if they do come back after treatment, they tend to come back, within the first few years. Hormone receptor positive breast cancers tend to grow more slowly than those that are hormone receptor negative. Now, if they do come back, which can always happen, they might come back many years after treatment. And the other thing to note too is that hormone receptor negative cancers occur more commonly in women who haven't yet gone through menopause. In terms of response rates to endocrine therapy, for women who have both estrogen and progesterone receptor positive disease, the typical response rate is pretty high, 75 to 80%. If one has only estrogen receptors and they are PR negative or progesterone receptor negative, then it drops down to 40 to 50%. If one is ER negative but PR positive, then around 25 to 30%. But if they have hormone receptor negative disease, then it drops to 10% or less. And so that's why we also, again, do not give endocrine therapy for these hormone receptor negative breast cancers. How do we interpret whether or not someone has hormone, is hormone receptor positive or negative? So cancers, and this is based on immunohistochemistry staining or IHC, cancers with less than 1% staining for ER, estrogen receptor, are considered ER negative. That means that they're not shown to benefit from endocrine therapy. Cancers now with at least 1% of cells are positive for estrogen receptors are considered ER positive, and so they are eligible for that. But there is a small group where cancers might have hormone receptors that are about 1 to 10%, that show 1 to 10% positivity. And so those are defined as low ER positive, as you can see in this table. What that means is that there's just more limited data in terms on the benefit of endocrine therapy for this group that have, a lower positivity rate, but they're still considered eligible because there's still possible benefit from getting endocrine therapy. The important thing to know, though, for people with, lower hormone receptor positivity is that, this group is known to be heterogeneous, and the biologic behavior of these ER low breast cancers could act more similarly like your estrogen receptor negative cancers. So it's still considered in terms of decision making for other adjuvant therapy, for instance, chemotherapy, things like that. And this table, also applies to progesterone receptors as well. So HER2 stands for Human Epidermal Growth Factor Receptor 2. Healthy HER2 receptors are seen on normal breast cells. They help manage how the breast cell grows, how it divides and how it repairs itself. But in about 25 to 30% of all breast cancers, the HER2 gene, the receptor, is not functioning properly. They're making too many copies of themselves. They're overexpressing themselves. So you might hear the term HER2 gene amplification or HER2 protein overexpression. And in that case, if there's any of this going on, then that's when we define one's breast cancer as HER2 positive. And HER2 positive breast cancers can be treated with targeted therapy, like HER2 monoclonal antibodies, or a kinase inhibitor. And kinase inhibitors basically down-regulate the signaling of that HER2 gene. So this is again crucial and important to know in terms of one's breast cancer diagnosis. The HER2 receptor testing is definitely different from estrogen and progesterone receptor testing. It can be a little bit more confusing, so I'm just going to simplify this, especially for our patients. We also use IHC, immunohistochemistry staining, for HER2 testing. This is what we start off with. And if the IHC result is either 0 or 1+, if you look to the right, near the bottom, 0 or 1+, then that's when we consider the cancer as being HER2 negative. So these cancers would not respond to drugs that target HER2. If the IHC is 3+, then we consider that HER2 positive, and we would obviously certainly treat those cancers with HER2 targeted treatments. When it's 2+, that's when it's sort of unclear, and that's when we call it equivocal. So there's a reflex test where if this is seen, then it reflexes to a test involving FISH, or fluorescence in situ hybridization. And basically what that test does is, it takes a better look, meaning it looks for extra copies. It sort of quantifies, those copies of the HER2 gene, and that will give us an answer of whether or not someone has the HER2 receptor. So moving on, I'm going to discuss genomics, and basically, it's a very good question in terms of deciding, whether or not people need certain treatments later on down the road. So, for instance, should my tissue from, my biopsy or surgery be sent for gene expression profiling to figure out if chemotherapy might be helpful for me? Or are there molecular tests that should be done on my tissue or even blood to help guide treatment options? So there's something called gene expression profiling, and again, this has revolutionized, the treatment landscape for breast cancer. And again, I will spend a lot of time, or a lot more of my time, speaking about this Oncotype recurrence score. So basically, just to start off with, due to genomic advances, we are able to now provide personalized medicine such that treatment is tailored to that one individual's, particular cancer. Gene expression testing can help predict who will most likely benefit from adjuvant chemotherapy, in addition to endocrine therapy for these hormone receptor positive breast cancers. And before I go on further, we don't test this in everybody, because if all of the clinical factors, that are used to predict the chance of cancer returning show that someone's already at very low risk, then these gene expression profiling tests might not be necessary. Same thing, in the extreme end, right? In the opposite end, if someone has a clearly aggressive cancer in which there is benefit from, say, chemotherapy, then this test might not be necessary either. But for cancers, and there are a lot of cancers that fall between these two categories, a decision does need to be made about, hey, what treatment would this patient benefit from? And so this is when gene expression profiling can be very useful. Gene testing genomics, basically these gene expression tests analyze various genes in tumor samples to predict the risk of cancer recurrence. Here you can see on the screen that there's a list of biomarker assays that help us guide decisions on adjuvant systemic therapy for early stage hormone receptor positive breast cancers. And they include the Oncotype DX 21 gene recurrence score, MammaPrint, EndoPredict, Prosigna, as well as something called the breast cancer index. And although several prognostic assays are available to estimate one's recurrence risk, the Oncotype recurrence score is preferred by NCCN guidelines because it's the only test that's been validated for predicting the benefit of adding adjuvant chemo to further reduce that risk of breast cancer recurrence. And so whenever a gene expression profile is indicated, the Oncotype recurrence score is, what we obtain, because the vast majority of, say, prospective research trials as well as clinical experience, they are based on this assay. And I did also want to add that the breast cancer index, which I won't be going into tonight just because there's a lot to discuss, the breast cancer index is another test that can be used to determine whether someone, that can help determine whether someone might benefit from, say, extended adjuvant endocrine therapy. So for instance, usually the recommendation, for instance, is 5 years, right? But if someone's got a higher risk cancer, then potentially 10 years might be beneficial. So the Oncotype DX recurrence score is a 21 gene assay that predicts the 10-year risk of distant recurrence, meaning the 10-year risk of cancer appearing anywhere else, in the body, meaning liver, lungs, and bones, as well as the likelihood of chemotherapy benefit in addition to endocrine therapy. And this is assuming that the patient is taking endocrine therapy for 5 years. So it helps guide treatment decisions. It is the most validated gene expression test, and it has been shown in multiple clinical studies involving about 4,000 patients. Over 900,000 patients worldwide have received their information from Oncotype's recurrence score, and over 19,000 doctors have ordered Oncotype DX in more than 90 countries. So it's definitely widely used. Which patients might benefit though from this Oncotype score. Not everybody. Basically, the Oncotype score provides information for node negative or women with 1 to 3 positive lymph nodes in estrogen receptor positive HER2 negative breast cancers. So if one had metastatic disease, if one had locally advanced breast cancer with 4+ lymph nodes, HER2 positive disease or triple negative breast cancer, they would not benefit from getting this Oncotype score. It's not indicated for those subtypes. The Oncotype score is calculated based on the expression of 16 cancer-related genes, as you can see here in this top left corner, as well as 5 reference genes. And you can see that, it includes Ki67, it includes ER, PR, HER2 as well. And the calculation is based on this, in this area to the right on your screen. This has been extrapolated from 3 studies and also clinically validated in multiple independent studies. This is an example of what the recurrent score report looks like. At the top, you can sort of see, Jane Doe, basically the patient's information, the specimen source, from which specimen the Oncotype was done on, say, for instance, the biopsy or the surgical specimen, who ordered it. And at the very top, underneath that title, Oncotype, you can see that says node negative. So there's different reports for node negative and node positive, okay? The 3 important numbers that patients should always look at is 1, that recurrence score that's circled, and those 2, percentages basically next to it. And I'm going to go into that now in terms of how to interpret it. So the recurrence score ranges from score of 0 to as high as 100. And in general, the lower the recurrence score, the lower the risk of breast cancer coming back at 9 to 10 years in a distant place, again, meaning liver, lungs, bone, etc. And this is on endocrine therapy alone. That also then translates to the lower the likelihood of chemotherapy benefiting in decreasing that risk of breast cancer recurrence. So I'm going to first focus on how we interpret this in node negative patients, and then I'll go into the node positive because it's it's done differently. First, though, we look at tumor size. So for patients with what we say T1A N0 disease, meaning N0 means no nodal involvement, and T1A just means that the tumor is 0.5 centimeters or less, we typically don't administer chemotherapy because these patients have such an excellent prognosis with endocrine therapy alone. So as you can see here, if the tumor size is not greater than 0.5 centimeters, then endocrine therapy only. But if it is, then there could be an indication to check the Oncotype score. So for patients with estrogen receptor positive breast cancers who are node negative, they derive significant benefit from chemotherapy if their score is at least 26, so it's 26 to 100. Whereas if patients who have a score of 25 and lower, 0 to 25, there's no benefit to adding chemotherapy to endocrine treatment for these women. And this is in particular for women older than 50 years old. For younger women, and that's defined as women 50 and younger, with an intermediate score, and their intermediate score cutoff was 16 to 25, there was shown to be a small benefit in terms of adding chemotherapy. But I do want to emphasize, I'm going to say this again, that benefit, it was unclear if it was from the chemotherapy itself or if it was from the ovarian suppression effect that was, induced basically by the chemotherapy in these premenopausal patients. So how do we get these numbers that you see on the screen? How, is this test able to say consistently identify that 80% of patients who can avoid chemotherapy and its toxicities, and how to identify the 20% who might significantly benefit from chemotherapy? Well, there are, studies out there obviously proving this. And the first study to validate the recurrent score test, the Oncotype test, was NSABP B14. NSABP stands for National Surgical Adjuvant Breast and Bowel Project, but that's what it is for short. Basically, this was a prospective trial involving over 600 patients with ER-positive node-negative breast cancer. And the primary objective in this study was to determine whether the recurrence score was prognostic of one's 10-year risk of distant recurrence. And if you look at this figure, this table right here, basically, we look at the risk categories. There were 51% of patients in the low risk category. This low risk was defined as those with a recurrence score of less than 18. 22% were in the intermediate risk. That was defined as a score of 18 or higher, but less than 31, and high was anyone with a recurrence score of greater than 31, and there were 27% of patients in that group. What it showed was that the 10-year rate of distant recurrence was significantly lower in that low risk group, about 7%, compared to those who were in that high risk group. You can see about 31%. And this was also significantly associated with a distant relapse-free interval, as well as one's overall survival. This was followed then by another study, the NSABP B20 study, and it was also again in about 650 patients with ER-positive, HER2 negative, node-negative breast cancer. And again, this objective, their primary objective was a little bit different. They wanted to delve in deeper. They wanted to see whether the recurrence score predicted the likelihood of chemotherapy benefit. So patients were randomized to either receive chemotherapy in addition to, say, endocrine therapy, or just be on endocrine therapy alone. And so when they looked at a number of clinical variables, and that included age, that included tumor size, the grade, the hormone receptor status too, what they found was that the recurrence score was the strongest predictive factor for chemotherapy benefit. So if you look at this figure here, basically what it shows is that if you look at figure B, this is looking particularly at patients with low risk recurrence score, again, less than 18. There's basically, and the blue line indicates tamoxifen or endocrine therapy plus chemotherapy versus the red dotted lines is endocrine therapy alone. And there's practically overlap. So what it had shown is that there was minimal, if any, benefit from getting chemotherapy in addition to endocrine therapy. Whereas those who had high scores, at least 31 was their recurrence score, right? If you look at figure D, this is the high score group. You can see how much benefit they got from chemo and endocrine therapy to decrease that risk of distant recurrence. If you look at figure C, this sort of brought up the $1 million question. There was, some uncertainty about whether or not patients, in the intermediate risk group, meaning a recurrence score of 18 to 30, benefited from chemotherapy in addition to endocrine therapy. So, what about chemo benefit in the intermediate risk group? And I will get into why I have, recurrence score of 11 to 25, which is different from the other cutoff that you had seen previously, because this is what was studied in the TAILOR-X trial. It was a huge trial, again, another trial that just changed the treatment landscape. And it was a prospective randomized trial that was sponsored by the NCI, National Cancer Institute, and it was coordinated by ECOG-AGRIN. It was the largest breast cancer trial looking at over 10,000 patients, ER-positive, node-negative patients from over 1,000 sites in 6 countries, dating back from 2006 to 2010. They followed these patients, and basically after 9 years, in 2015, they saw that more than 99% of women, and that equated to over 1,600 women with a low recurrence score, and this was 0 to 10 was the recurrence score, who were only on endocrine therapy for 5 years, did not have distant breast cancer recurrence. So this provided, with all the data, with all the, participants involved, this provided the highest level of evidence that there was a less than 1% risk of distant recurrence at 5 years in patients with a recurrence score of less than 11 who were treated with hormone therapy alone. This definitively demonstrated that women with a recurrence score of 0 to 10, node negative, could forego chemotherapy, and it established the Oncotype recurrence score as the standard of care moving forward. Then in 2018, the trial also showed a non-inferiority of endocrine therapy alone compared to chemoendocrine therapy in patients with a recurrence score of 11 to 25, that intermediate or that mid-range group. And it showed that specifically with invasive disease-free survival, freedom from disease recurrence at a distant site, at a distant organ, distant or local regional site, and overall survival. But there was a minor difference. So when they did, subgroup analyses, when they looked at particular groups, according to age, they saw that there might be a small benefit of chemotherapy in women who are 50 years or younger with a recurrence score of specifically 16 to 25. And as I mentioned earlier, it was unclear if this benefit could be due to the ovarian suppression effect that occurs from chemotherapy in these premenopausal patients. And typically, basically, what that means is that women who are, younger, younger than 45, typically these patients are unlikely to go into a permanent menopause from their chemotherapy, whereas women who undergo chemotherapy, who are older than that, are more likely to be entering menopause anyway, regardless of it, right? And so there was this question of whether this chemo-induced premature menopause, had anything to do with that, with this finding. And so as a result, in this particular group, there could be recommendations where say, hey, in terms of endocrine therapy, that could be given with, say, ovarian suppression, especially in these, women with a higher, intermediate recurrence score. So moving on to specifically node-positive disease now. The trans-ATAC study further validated, again, that the recurrence score result provides, the risk of distant recurrence in patients with ER-positive, HER2-negative breast cancer, not only in node-negative disease, but also node-positive disease. So as you can see from the figures here, A is node negative and figure B is those with node positive disease. And it did demonstrate that, the 10-year rate of distant recurrence was significantly lower for patients who had a low recurrence score compared to patients with high recurrence score. SWOG 8814, I think Southern Western Oncology Group is the full name. But anyway, this trial also confirmed that a low recurrence score of less than 18, and they used the cutoffs that were similar to the NSABP trial. A low recurrence score of less than 18 predicted little to no benefit from chemotherapy, while a high score, at least 31 plus, predicted a significant benefit from chemotherapy. Then again, we're looking at the intermediate group. Well, what about this intermediate group? And what about pre and postmenopausal status? So more recently, our Exponder trial was a huge trial. Again, more treatment advances and things like that. So, excited to present this data, and it was, also recently discussed at San Antonio. But anyway, this was a prospective randomized trial that evaluated over 5,000 hormone receptor positive, HER2 negative, node positive, up to 3 lymph nodes, patients with recurrence score of 0 to 25 to receive chemotherapy and endocrine therapy versus endocrine alone. So this looked at 0 to 25, so low, intermediate, and they looked at invasive disease-free survival, IDFS, stratified by 2 groups, postmenopausal and premenopausal groups. What it showed was that if you look to your left in terms of the postmenopausal group, among postmenopausal women, the IDFS at 5 years was about 92% on endocrine therapy alone versus almost 92% in the chemo endocrine therapy arm as well. So there was no statistically significant difference in this group. So meaning that postmenopausal women with 1 to 3 positive lymph nodes and a recurrence score of 0 to 25 could forego adjuvant chemotherapy regardless of their, clinical and their pathological parameters. In terms of the premenopausal group, when we look at this, it shows that the 5-year IDFS for women who were on chemoendocrine therapy was 94% versus 89% in women who were only on endocrine therapy alone. So there was a statistically significant difference in this group, and that was by about 5%. So in this particular group, premenopausal women with 1 to 3 positive lymph nodes and a recurrence score of 0 to 25 did significantly benefit from getting chemotherapy in addition to endocrine therapy. And this is really, this summarizes what I had discussed in terms of, the trials that were done and things like that. So just to summarize, basically for all women, for all breast cancer patients, hormone receptor positive, HER2 negative, regardless of nodal status, regardless of age and post and menopausal status, if the recurrence score was 26 and above, meaning if they had a high recurrence score, they had a substantial benefit from getting chemotherapy in addition to endocrine therapy. If, however, for women who were older than 50, did not have any nodal involvement, who were postmenopausal with nodal involvement, meaning 1 to 3 lymph nodes, and had a recurrence score of 0 to 25, they could potentially forego chemotherapy. For women who were 50 years and younger, no nodal involvement, there was also no chemotherapy benefit for that low recurrence score. But in terms of the intermediate range, 16 to 25, there could be a small benefit, as you can see here in that second row. And again, it's unclear if that could be from the ovarian suppression effect of chemotherapy. Now, for the premenopausal, for the premenopausal group with nodal involvement, doesn't really matter what the score is, but there's, again, a chemotherapy benefit in that group. So moving on to tumor markers. In breast cancer, there's usually an increase in the production of certain proteins, like cancer antigens, that can be shed by the tumor itself and get into the blood. And so these proteins can be measured through blood work to determine whether, say, breast cancer has potentially spread or progressed, or if there's a recurrence in terms of breast cancer. It's most useful in evaluating treatment, though, in stage 4 metastatic breast cancer. Tumor markers are not by themselves reliable enough to diagnose breast cancer and to make decisions about treatment. They can help, but they are not useful enough on their own to do any of this. So that being said, if elevated, tumor markers can be followed to assess treatment response or progression, and like I said, that can help guide management and treatment options down the road. We typically follow 3 tumor markers in breast, and that includes CEA, carcinoembryonic antigen, cancer antigen 15-3, and cancer antigen 27-29. The trend in the levels, is important. So for instance, if levels are high at diagnosis and they, decrease, as treatment goes on, then that's a good sign that, that the treatment's probably working. But if at some point while that patient's going through that treatment and there's a steady progression back up, then it's likely that the cancer, is no longer responding to that treatment anymore. Another thing to know is that not all patients, not all cancer produce, tumor markers. So not all patients have these tumor markers. And if that's the case, then it's not very useful in terms of monitoring treatment response. So like I said, they're not used as a screening tool to diagnose breast cancer. They have to be used along with other tests because, one, they can be non-specific, meaning, other cancerous and even non-cancerous conditions can bring up those values. For instance, abnormal liver, if someone has an abnormal liver function, these tumor markers are typically cleared through the liver. So if they're not being cleared, they're going to be up and they can be falsely elevated as a result. As I said before, not every patient produces cancer or these tumor markers, and an isolated increase, one solitary, increase basically in tumor markers should not be used to say that someone has progressed. That being said, for any patients who have bone dominant, meaning primarily bone metastatic disease. Changes in bone lesions can be difficult to assess with, certain imaging like X-rays and bone scan. So for those reasons, the symptoms as well as, following tumor markers, that might actually be more helpful in this particular group of patients. So I am running out of time, but I do want to just give you examples of why these are not, again, meant to be used to diagnose, to screen for breast cancer, because they are elevated in other cancers, they are elevated in other benign conditions. CEA in particular can be elevated in colorectal cancer, and colorectal cancer is the most common cancer that makes the CEA rise. Same with CA15-3. It's also found in other benign hematologic conditions like sickle cell, thalassemia, CA2729 as well. So I want to briefly talk about circulating tumor cells because this has become more of a hot topic in cancer in general. Basically, detection of circulating tumor cells in the blood, and that's defined as at least 5 cells per 7.5 cc's in patients with metastatic breast cancer, has been shown to be of prognostic value. There was a pooled analysis that was done of almost 2,000 patients from about 20 studies with metastatic breast cancer. And in these studies, it showed that patients with elevated circulating tumor cells did have shortened progression-free survival, PFS, as well as OS, overall survival, compared to those without elevated circulating tumor cells. Also, patients with rising circulating tumor cells at weeks 3 to 5 of treatment had worse PFS and OS too. But the clinical use of circulating tumor cells in metastatic breast cancer isn't included in NCCN guidelines for disease assessment and monitoring. And why is that? There was a trial that basically, looked to see whether there was a role of CTCs in terms of guiding treatment decisions for women with metastatic breast cancer. And this was prospectively studied in this trial, which evaluated CTCs at baseline and after 1 cycle of first-line chemotherapy in almost 600 women with metastatic breast cancer. And if those circulating tumor cells remained elevated after 1 cycle, then patients were randomly assigned to either continue their treatment, stay on the same treatment, or change their treatment. And as you can see here, so the blue line, basically has the patient still on the same treatment. The yellow line means that they changed therapy. There's basically overlap between the two. The left, figure A, shows overall survival, and figure B shows progression-free survival, PFS. There was no difference in OS or PFS, which is why circulating tumor cells should not be used to influence treatment decisions in metastatic disease. And so that's why, as of right now, it's not, recommended in terms of from the NCCN guidelines. And just quickly, again, there's just so much to talk about. I can't go through everything. There are additional biomarkers that can be done to look for other therapies in metastatic breast cancer. Specifically, for instance, PIK3CA mutation in hormone receptor positive HER2 negative disease. There are FDA-approved agents for that, alpelisib. In triple negative breast cancer, metastatic disease, PD-L1 is what we use too, and to see if someone might benefit from, say, immunotherapy. And patients with, say, BRCA germline 1-2 mutation, PARP inhibitors like olaparib and talazoparib can be used as well. So it's just, there's just a wide range of treatments nowadays, and it's just amazing how far we've come in this field. And genetics, I'm not going to go into that. Dr. Zara is going to discuss that at our next breast cancer lecture series on April 12th. So I hope you guys can attend that. I'm sure that will be very, very helpful. But thank you, everybody. Any questions?
Thank you so much, Dr. Phuong, for just a really well-organized, very comprehensive presentation. I think it really brings to light just the incredible amount of information available to us now to fine-tune the diagnostic workup process and And also just in the formulation of the final treatment plan, which is often a work in progress, just almost mind-boggling how individualized a treatment really can be for our patients. So much on the horizon too, but really very encouraging news. I'm also really pleased that this presentation was taped for our archives, because I think what you bring up is so much the questions that our patients have that often they may have heard during the consultation, or perhaps in speaking with their friends or reading the statistics. This presentation really and truly is right from the source, our medical oncology experts. So we certainly encourage patients to have these discussions directly with your doctors to offer clarification. We are here as the support team to help along the way. We're at the end of our time for questions, but any of you listening, you can submit questions after the fact. We'll stay on a little bit. We'll keep the chat room open in a little bit for a little bit if you want to submit questions. Otherwise, any of us on the team here can field questions to Dr. Phuong, who will answer them and we'll get them back to you. Lovely to end with the slide of our future doctor in the making, always looking for new talent. So thank you again, Dr. Phuong. So lovely to be with you tonight, and we wish everyone a very nice evening. Take care.
Thank you, Michelle. Take care, everybody.
Thank you. Thank you. Good night. I don't know if you remember me. This is